Welcome back. We are on our second uh, installation of Angela's presentations. If you're wondering why we are at our homes, it's because Angela unfortunately was sick at the time that her presentations were to be done during classroom hours. So we're catching up. I don't know about you. I'm in my pajamas. I haven't put on any makeup today.
I have t-shirt and sweats, so
Who cares, right? Who cares?
that's right. No makeup,
So
yes.
we're going to go ahead and get started. Angela, do you still have your screen share?
I do. Here we go. All right, we ready?
All right. Yes.
All right, there we go. Okay, this is on psych and behavioral. Some of us like psych, some of us don't. But anyways, behavioral and psychiatric disorders are the fifth most common emergency that EMS professionals respond to, accounting for almost 8% of all EMS calls. All right, let me let me start my slideshow.
Just 8%.
Yeah, right? It seems like a lot longer for Fulton, a lot more for Fulton County, doesn't it?
I would say at least a quarter.
You would think. Maybe we just have more crazies in Fulton County than the rest of the United
So
States.
where were these statistics out of?
I can double check. I'm not sure, but I can double check for you and show the link, share the link. So, but yeah. Behavioral and psychiatric disorders are behavioral or mental patterns that cause significant distress, impairment of personal functioning. The condition may be persistent, relapsing, and remitting, or occur as a single isolated episode. The psychiatric conditions associated with psychiatric emergencies include schizophrenia, bipolar disorder, especially bipolar mania, depression, anxiety states. That's it.
So interesting.
No, there's more. Intoxication. What?
Bipolar 1 is the mania. Bipolar 2 is more control.
Bipolar, yeah. Intoxication. Withdrawal. I have a story about withdrawal. I'll share it with you. Delirium, which is not actually a psychiatric condition. Dementia, which we all know is not a psychiatric condition. Okay. Medical causes that can mimic psychiatric condition symptoms include, we all know, diabetes or hypoglycemia, delirium, mental retardation, hyperthyroidism, dementia, hypoxia, seizures, hypoglycemia, HIV encephalopathy. What other medical conditions can cause psychiatric symptoms?
Potassium.
Who?
Low potassium.
Low potassium. What about UTIs?
Yeah.
I mean, so so there's a couple more. Don't you like my little psych patient right there? Huh?
Head injuries.
Head injuries, yes. Yes. The patient who is experiencing a behavioral emergency should receive the same history and physical exam as any other patient, with an eye toward the differential diagnoses of the altered mental patient. The patient who is experiencing a behavioral emergency. Okay, I had to read it over again to make sure I understood it. You see my little picture there? Patient wants pain meds. EMS says, well, when we drop you off, if you act crazy, they will give you the good stuff. Anyways, oh, crack me up. I cracked myself up. I gotta move you. Care for the behavioral emergency patient. Just as the assessment of a patient experiencing a behavioral emergency may seem subjective, the lack of steadfast rules in caring for the behavioral emergency continues the challenge for EMS providers. Following are a few concrete guidelines for patient care. First and foremost, ensure safety during the scene size up and throughout the call. You know, a lot of times when we have our behavioral and psych, we are calling for law enforcement. That's it. We are calling for law enforcement. While not all behavioral emergency patients will be out to hurt themselves or you, caution is always warranted, and we are so good. Yes. Seek law enforcement assistance early in the call. If patient is agitated by the presence of law enforcement, have them leave the immediate area. We can have them stand by outside. We can have them, you know, even just go around the corner into another room. If patient responding positive to a bystander, have them stay. You have EMT, you have paramedic. If the patient is responding more to that EMT than the paramedic, you know, I mean, especially when you have a female patient and a male paramedic, there's a lot of times the female patient does not want to talk to the male paramedic, but we'll talk to the female EMT. Take suicidal threats seriously, homicidal until proven otherwise. When safe, get to eye level with the patient and maintain eye contact. Yes. Let one person do the talking. One team member should speak with the patient when establishing verbal contact and building rapport. This will avoid conflicting instructions from different responders and limit confusion. Yes, I know that the paramedic is your primary care, but again, if the patient is not responding to the paramedic or is responding and doesn't like the paramedic, doesn't want to talk to the paramedic, let the EMT get in there and do the talking. Some of us EMTs can be the good cop. Some paramedics can be the bad cop. You know what I'm saying? I know there is a certain psychiatric patient that I am short with, but some of the paramedics are like, take really good care of her and treat her with the respect that she deserves. Okay.
I have a story after we get done.
Okay. This will avoid conflicting instructions from different responders and limit confusion. Other responders can remain nearby if assistance is needed, perhaps even out of sight, to avoid a show of force, appearance, or making the patient feel surrounded. Okay, go ahead.
It'll have to be after we get done.
It what?
It'll have to be after we get done when it's
Oh, when I'm all done. Okay. A good place to start regarding rapport building is by letting the person know you are here to help and asking what help they may think they need. As the second responder, look for medications, drugs, alcohol, anything that can be used as a weapon. Maybe not toward EMS, but maybe the patient had plans. So you may see a knife out in the bedroom, or a knife where it really doesn't belong. Where do knives belong? Knives belong in the kitchen. You may see it in the bathroom or the bedroom. You know, that's good to make note of, especially medications. A lot of people will have behavioral or psych, I can't even think of the word for it, because of the medications they're taking, or maybe they took too many of them medications, you know?
Side effects.
Right. So the second responder can go look and say, hey, look, I found this medication. There's supposed to be 60 in there. There's only 2 left. You know what I'm saying?
Yeah.
Very, very helpful. Because a lot of times your first responders, they're not going to look for that stuff. They're not going to know to look for that stuff. Your law enforcement, are they going to know what that medication is for? You know what I'm saying? I mean, but so that second person can start looking for indications of what we might be into.
Mine will know some.
Right. Once the sample
I try
history,
to. Go ahead.
Go ahead. No, you go ahead.
I try to, when we do like the training, the first responder training, I try to give them like the most used, and that way they're a little bit familiar when they see those.
Right, right. And that's good. And I got a story for you. Oh, let me tell you something real quick after we're done with this. Once the sample history and physical exam are completed, and you believe that you are in fact dealing with a patient experiencing a behavioral emergency, move to the mental status examination. This examination performed routinely in both out and inpatient facilities will allow you to obtain pertinent psychiatric findings not present in the sample history. The sample history is what we learned in school. It's what we all learned in the sample history, as well as accurately and intelligently document the patient's psychiatric signs and symptoms. Components of the mental status examination include appearance and general impression. How does a patient appear to you? Are they clean? How are they dressed? Do they have purple polka dots with zebra stripes? You know, how is he acting in general? Note the patient's attire. See, there's the patient's attire and level of hygiene. Affect. What is a patient's affect? Often defined as the outward projection of the patient's mood or behavior. Again, they will show agitation to other people, to many people. They will show agitation to different sexes. Females don't want anything to do with the males. Males think females are stupid. It ranges. And again, it may range from excited to flat.
That just looked like a good party. In
Right?
that picture.
Right? Anyways, thought process. Does a patient's thinking make sense? Is it in keeping with his environment? Is there a consistent association between his thoughts? Is there evidence of hallucination? We have seen patients say there's somebody out to kill me. There's people in my yard. Just stuff like that. Okay.
Laser.
So, right. All right. So the story I was going to tell about the withdrawal. Me and my partner last week, we had a call out to Viola for a patient that was experiencing, for a patient that stated he had swelling in his hands and face. So we get on scene, and officers on scene, and we get on scene, and the patient's sitting outside, and he swears his hands and his face are swollen. So we look, there is no swelling in his hands and face. So the subject of meth comes up, and my partner asked, when was the last time you did meth? And the patient said 3 days ago. He was going through withdrawals, and we tried to explain this to him. You're feeling that way because you are going through withdrawals. And then he says that he hasn't had a bowel movement in 3 weeks. Well, you know, you really don't seem like you haven't had a bowel movement in 3 weeks. And he said, no, wait, listen. I think I have a parasite. And you know, that parasite can be addicted to that meth. Okay, do you want to go to the hospital? No, I think I'll be okay. Okay. Since when do parasites get addiction to meth?
That's about as bad as Granville's patient being assaulted by a bubble.
Assaulted by a bubble. I hope you
Yes.
told Tim that one, because let me tell you, Tim has been in this business for a long time, and I guarantee he's never heard that one. Never heard that one. Because he's never heard about the parasite being addicted either. So, yes. Anyways, I feel sorry for the kid, because, you know, we even suggest, if you got this parasite that's addicted, you might want to go get checked out. You know, especially if you haven't had a bowel movement in weeks. But anyways, he didn't go. Does the patient feel he has any special ability, Superman, or powers, or believe he is someone he isn't?
Was
Does the
your patient able to answer the pertinent questions? Person, place, time, situation?
I haven't got there yet. I don't even know if I got that yet. I don't even know if that's on here. I guess we'll find out together.
No, I mean
What?
your patient, your meth patient.
Was he? Oh yeah, he was asked all the questions.
Isn't that crazy?
He was asked all the questions, you know, and he, what did he say? He was living in a trailer. The trailer was a mess. He was going through a divorce. I mean, yeah, he answered everything. I take it back. He may have been off a day, but who's not off a day? You know what I'm saying? I think it was like on a Tuesday and he said it was Monday, but half the time I don't even know what day it is. And so I mean, yes, all the other questions he answered correctly. Yes. Does the patient feel he has any special ability? Does the patient feel as if he is being watched or controlled by an outside force? These are called delusions. Aliens are coming to get me. Your FBI, CIA. Anyways, observe
Well,
the
the
patient's
aliens aren't
speech.
so far-fetched anymore.
As an indicator of thoughts, okay, as well as a sign in itself. Does the patient speak? Does the speech appear pressured as though words are forced out when the mouth is opened? Is speech slow or monotone? Which, anyways. Judgment and insight. How does the patient feel he is doing right now? Does he feel he needs help? Has the patient done or suggested anything? Taking off their clothes in public or in cold temperatures, running in traffic, that indicates judgment that is questionable or harmful. Has a patient mentioned or attempted suicide? Observe for and maintain an open airway. I don't know how we can maintain an open airway on a psych patient that doesn't want to be touched. And it could be like our UTI and hypoglycemics. Consider all patients experiencing unusual behavior or having altered mental status until proven otherwise. This tenet of care has saved many providers from a lawsuit when assuming a diabetic, stroke, or disabled patient was really a psych. Remember that medications taken for psychiatric conditions are extremely dangerous if taken in excess, which I know we have all experienced something like that. Treat all medical and traumatic conditions, which we always do. Much of the care we give is interpersonal, not clinical. After ensuring safety and ruling out treatable medical conditions, our interpersonal dealings with the patient form the bulk of our care. Sorry. Be calm and direct. Don't hesitate to talk to the patient about his or her condition. In fact, it is often better to be direct and respectful rather than tentative and uncomfortable. If you can't talk about a patient's condition with him, he won't talk to you. Use appropriate body language. Show interest and openness while maintaining a safe position and distance. Avoid looking disinterested or using closed body language or saying, you know what, just get in the truck. Have a plan. Patients are surprisingly receptive to a plan expressed confidently. Conversely, patients will detect hesitance in your voice. Explain slowly and clearly what you are going to do. Patients who feel they are losing control may respond positively to this. I am going to take you to the hospital. The police are going to help us get to the ambulance, and then I'll put you in the stretcher for the trip. This is stuff that you need to be saying to the patient. And we're going to take good care of you. Asking whether the patient wants to go to the hospital when there really is no choice is counterproductive. Okay, but we still have to ask, don't we, if the patient wants to go? I mean,
Well, I mean, there's been several times that I've went out that families called and the patient, for whatever reason, they're able to answer the pertinent questions or and they don't want to go. And of course, we have to AMA those, or like the UTI where they're just belligerent, getting the patient, because you can't force them to go.
no,
You have to coerce them to go. And most times they don't know, the appropriate questions to be, the answers to the appropriate questions to be asked. So it doesn't happen a lot of times either.
right. Never play into delusions. Don't agree with or further a patient's delusions. So if there's somebody, if they think that CIA is out to get them, don't agree with them. If they think they see little Martians outside, don't agree with them. It is unprofessional and counterproductive to the patient's care. Many times a part of the patient is clinging to reality and he will sense patronizing behavior. We do not restrain. If we feel the patient needs restraints, an officer needs to be present during transport. As far as refusing to care for the patient because you feel threatened, tell the officer, I can't transport with the patient behaving like that. Our safety comes first. There have been
I've
times,
had
huh?
I've had law enforcement do pat downs before we
Oh,
put them
that's a good
into.
idea. That is a really good idea. There have been times where sometimes a law enforcement can calm a patient down if the patient knows that law enforcement officer.
Yeah.
And unfortunately, officers use the phrase, and we've all heard it, you can either go with EMS or go with me to jail. Well, which would you choose? I mean, and sometimes that does calm a patient down. And there's been the occasion where just take me to jail. I don't care. So I don't know. Again, if you feel threatened, tell an officer. If a patient has to be handcuffed, an officer has to go with you. Because we are not going to be responsible for making sure them handcuffs stay on. Nothing like that. It's not our choice for that patient to be handcuffed. It's the officer's choice. They have to go with you. Oh, that's it. I'm all done with that. So are there any questions, any concerns? Did I miss anything? There's a lot that can be found on Google. So that's it. I'm done. So.
Yay! Thank you so much.
And
Appreciate
there is that one psych patient that we go on all the time. And like I said, we get to the point where it's like, get in the truck, which is bad behavior. I will admit to that. And she has tried to cut herself. But she's one of those that is not getting any help,
Yeah.
and it breaks my heart. But yes, my behavior towards her could be better. I'll agree with that. But that's all I got.
Okay. I'm gonna stop recording.
Okay, stop recording.